you can see the deviation. It is a S-shaped deviation. Given on this side, the inferior turbinate is mulberry. So it's a case of deviated nasal septum with chronic rhinitis, and this patient has developed bilateral dacrocystitis. We are planning to do a endoscopic DCR together with the septoplasty. You can see the elected. This procedure is done under local anesthesia. Initially, we give a pre-medication of injection organ 20 mg and atropine 0.6 mg half an hour before surgery, and we pack the nose with 4% xylocaine, and then a local infiltration with 2% xylocaine with adrenaline. You can see I am injecting the local anesthesia into the anterior part of the nasal septum and also into the nasal septum posteriorly with a long needle. The infiltration is given from anterior to posterior on both sides of the septum and also on the floor of the nasal cavity. There you can see local infiltration into the posterior part of the bony septum. The mucosa there. After the local infiltration, a freer incision is made on the anterior part of the nasal septum. You can see the incision being made from below upwards on the anterior margin of the septal cartilage. Care being taken to see that the blade is held in the upward direction and the incision is carried on to the septal cartilage, anterior surface of the septal cartilage. A good incision helps in the elevation of the mucopericardial flap. There you can see the septal cartilage. Now you can see the wet cartilage, and the mucopericardium is elevated on one side from below upwards from the floor to the roof of the nasal septum. You can see the flap being elevated. Once you are in a proper plane, the elevation of the mucopericardium is very easy. The elevator just sweeps in and you can go from anterior to posterior without any difficulty. So the plane is very important. You must come to the cartilage proper and lift the mucopericardial flap on one side. There you can see the flap being elevated completely from anterior to posterior, from the floor to the roof, and there is hardly any bleeding. Clearly the flap is elevated on the opposite side, but here the flap is not elevated to the dorsum as it is done on the other side. This is to see that there is adequate blood supply to the cartilage on the other side. There you can see the cartilage being elevated on the opposite side. We are watching from the opposite side of the septum. the flapping elevated from the cartilage. You can see the mucoperiosteal elevator there. Now you can see the septum in between the two blades of the nasal speculum, and I am making a small cut in the inferior part of the septal cartilage. You can see the incision made on the lower part of the septal cartilage from front to back, and this small strip of the septal cartilage is removed. There you can see the inferior strip of the septal cartilage coming out. Catch it with the lux forceps and remove it. The incision is made near the anterior nasal spine. And on the upper surface of the maxillary crest. Now we would like to separate the mucoperiosteum on the maxillary crest. So make a good incision from front to back on the superior surface of the maxillary crest. Again, the blade is held in the upward direction, otherwise it will give a painful scar on the vestibule. Once the incision is made using a mucoperiosteal elevator, you separate the mucoperichondrium. There you can see the mucoperichondrium being separated on one side of the maxillary crest. The maxillary crest is clearly seen with a groove in between. The same procedure is done on the other side. Which we usually call it as tunnel number 2 and tunnel number 3. Now the posterior part of the bony septum is also separated. You can see the posterior part of the bony septum. The cartilage is detached from the posterior part of the bony septum. There you can see that I am separating the cartilage from the posterior bony septum, and the mucoperiosteum of the posterior part of the bony septum is also elevated. There you can see the posterior part of the bony septum, which is completely separated from the mucoperichondrium on both sides. Now using the nasal gouge, you remove the maxillary crest. First make a vertical cut. Now you can see the maxillary crest is removed. That is the maxillary crest. That is the posterior bony portion of the septum. the vomer and the perpendicular plate of the ethmoid. Catch it with the lux forceps, break it and remove the posterior bony septum. The bony septum. The patient is comfortably sleeping even in this, when you are doing this procedure, because we have given 75 milligram of injection pethidine intravenously. That is a vomer. Absolutely no bleeding. Suck both the nostrils. There is no perforation of the mucoperichondrium on both the sides. Now you can see the posterior part of the nasal cavity clearly. Initially it was very difficult to negotiate the scope. Now you can see it clearly. Using a 2030 catgut, you fix the mucoperichondrium of both the sides to the cartilage. Take a bite from one side. Bring a needle from the opposite side. There you can see the needle on the other side of the nasal cavity. Through and through, from the mucoperichondrium of one side, then the cartilage and the mucoperichondrium of the opposite side. Bring it out. Yes. Now again take it from this side to the opposite side. At an inferior level. Now the cartilage will be tightly adherent to the mucoperichondrium of both the sides. Once you put a suture, there you can see the needle coming out. that's the knot. One more similar suturing is done. I always put two sutures, one posteriorly and another anteriorly. There you can see the two stitches there. The two knots are seen clearly. And the mucoperichondrium is tightly adherent to the septal cartilage. And both sides mucoperichondrium is intact. Wound is closed. We can see the anterior incision. In SMR, usually you make an incision posteriorly, and that is called the Killian's incision, and this is the Freyr's incision. That incision is about 0.5 to 1 millimeter behind the mucocutaneous junction.